The videos that you will see in this series are to assist you with performing special tests to accurately diagnose an injury. All of the special tests performed in this series will have research that backs up and supports the efficacy of the test. Most tests will have a sensitivity or specificity assigned to it. Sensitivity is the ability of the test to correctly identify patients with a disease. Specificity, on the other hand, is the ability of the test to correctly identify people without the disease. Sensitivity refers to the test's ability to designate an individual with disease as positive. A highly sensitive test means that there will be few false negative results, and thus fewer cases of disease are missed. The specificity of a test is the ability to designate an individual who does not have the disease as negative. An ideal testing and screening is exquisitely sensitive, high probability of detecting the disease, and extremely specific, high probability that those with the disease will screen negative. So generally speaking, a test with a sensitivity and specificity of around 90% would be considered to be a good diagnostic performance.
In this video, we'll be going over the Thessaly's test. This is a test to determine the integrity of the meniscus and to diagnose a meniscus tear. The specificity and sensitivity of this test are both moderate, so it's a useful test, especially in combination with other meniscus tests, including the McMurray's and the Apley's test. To perform the Thessaly's test, the patient is asked to stand on one leg with their arms being supported on either a chair, table, or outstretched with the clinician's hands. The patient is then asked to bend their knees at about 5 degrees of flexion, and then to rotate the knee and body internally and externally 3 times. After 3 repetitions of that, the patient is then asked to bend the knee at 20 degrees of flexion and to repeat. The test is considered positive if the patient's symptoms and/or pain are reproduced, such as clicking, grinding, catching, etc. Next, we'll be going over the Apley's compression test. This test is used to assess for the presence of a meniscus tear. The sensitivity and specificity of this test are approximately 60 to 70% respectively. To perform the Apley's compression test, we will have the patient lie down in prone, like so. With the involved knee, we will flex it to approximately 90 degrees. Here, I'm going to stabilize the knee and compress downwards on the joint while I apply an internal and external rotation force, like so. The test is considered positive if it reproduces the patient's familiar pain and/or symptoms. Next, we'll be going over the McMurray's test. This test is used to assess for the presence of a meniscus tear. The specificity and sensitivity of this test are right around 70%. There are 2 ways to perform the McMurray's test, one for the lateral meniscus and one for the medial meniscus. The starting position, the patient will lie supine, and I'm flexing the knee like so. To assess for the lateral meniscus, I'll be placing my hand on the lateral joint line, and I'm going to apply an internal force on the tibia as well as a varus stress to the knee as I passively extend it like so, palpating. And to assess for the medial meniscus, we do the opposite, and I palpate the medial joint line, apply an external rotary force to the tibia and a valgus stress to the knee as I passively extend it, like so. The test is considered positive if it reproduces the patient's familiar pain and symptoms. To perform the varus and valgus stress test, the patient is asked to lie supine and then to bend the knee at approximately 30 degrees. To perform the valgus stress test, one hand will be placed on the lateral aspect of the knee and the other on the inner part of the ankle. A medial force is applied, like so. A test is considered positive if pain or laxity is noted on the inner part of the knee, indicating possible involvement of the MCL. To perform the varus stress test, it's performed almost the same way as the valgus stress, but now in the opposite direction. So we're having the patient lie supine, bending the knee at about 30 degrees. Now I'm placing one hand on the inner part of the knee and the other on the outer part of the ankle, applying an external force like so. If there is pain or laxity noted on the outer part of the knee, that could indicate possible LCL damage or involvement. One variation of the valgus and varus stress test is to have the patient fully extend their knee to keep the MCL and the LCL taut during the test. For this variation of the test, hand placement is the same, where one hand will be placed on the outer aspect of the knee and then on the inner ankle. For the valgus test, we're applying an internal force here. And then the opposite for a varus test. This test is called the anterior jar test. It is used to determine the integrity of the anterior cruciate ligament and to diagnose an ACL tear. To perform the test, the patient will be lying supine and the knee will be bent to 90 degrees or so. The hands will be placed right under the knee joint here, just behind the tibia, and I'm going to be applying an anterior force to the tibia on the femur, like so. A test is considered positive if there is laxity with this test and or reproducing pain. This is called the Lockman's test. It's used to determine the integrity of the anterior cruciate ligament and to diagnose a ACL tear. To perform the Lockman's test, the patient is asked to lie supine and then to bend the knee to approximately 30 to 40 degrees. Now with this test, it is useful to have one thigh under the patient to avoid excessive movement one way or the other. I've got one hand supporting the femur, just pushing downwards like so, and then my other hand will be right on the proximal end of the tibia here, and I'm going to be applying an anterior force on the tibia to the femur. A test is considered positive if the patient's pain is reproduced or there is laxity noted with the anterior force of the tibia. Next, we'll be going over the posterior jar test. This test is used to determine and assess for integrity of the posterior cruciate ligament and to diagnose a tear of the posterior cruciate ligament. To perform the posterior jar test, we'll have the patient lie down in supine, like so, and then we're going to bend the patient's knee to approximately 90 degrees. With my hands, I'll be taking them right under the joint line here, just at the proximal tibia, and I'm going to apply a posterior force on the tibia to translate it backwards. The test is considered positive if there's laxity within the joint and or it reproduces the patient's symptoms. Next, we'll be going over the pivot shift test. This test is used to assess for the integrity of the ACL and determining an ACL tear, as well as anterolateral rotary instability of the knee. This test has a high specificity of around 0.97 to 0.99, making it very useful for ruling in an ACL tear. To perform the pivot shift test, we'll have the patient lie down in supine like so. And with the involved leg, we're going to slightly abduct it. With one hand, I'm going to be placing on the foot, and I'm going to apply an internal rotation force on the tibia. With my other hand, I'm placing it on the proximal tibia. To perform the exam, we're going to apply a valgus stress and an axial load to the knee while we passively flex it, like so. A positive test is indicated by subluxation of the tibia while the femur rotates externally, followed by a reduction of the tibia at around 30 to 40 degrees of flexion.
The O'Brien's test is used to diagnose a SLAP lesion. It is similar to Speed's test. According to a meta-analysis of Hedges et al. In 2012, the O'Brien test has a sensitivity of 67% and specificity of 37% for detection of SLAP lesions. This test has two parts. The first is performed by asking the patient to flex the shoulders to 90 degrees and bring them into 10 degrees of adduction. Now, ask the patient to fully internally rotate the arm and ask the patient to resist the downward pressure. For the second testing position, ask the patient to fully externally rotate the arms. Now, give the downward pressure and ask them to resist. The test is considered positive for a SLAP lesion if the pain that is provoked during the first testing position is less or disappears in the second position. The Hawkins-Kennedy test is used to detect shoulder impingement. According to a large study conducted by the Hedges et al. In 2012, this test has a sensitivity of 80% and a specificity of 56% for detection of shoulder impingement. To perform the Hawkins-Kennedy test, have the patient in sitting or standing with the shoulder flexed to 90 degrees and the elbow at 90 degrees. Fixate the scapula with one hand and hold the patient's elbow with your other hand. Add passive internal rotation to the glenohumeral joint. This test is considered positive if you are able to reproduce the patient's familiar shoulder pain. The near impingement test is a test for subacromial pain or impingement syndrome. In a study performed in 2012 by Hedges et al., the near test has a sensitivity of 59% and a specificity of 60%. This test is performed with the patient in a sitting position. You stand behind the patient, and the patient, with one hand, you stabilize the scapula and then bring the arm into passive flexion. Some authors suggest that you internally rotate the shoulder, although Near's original description does not state this. The test is positive when you reproduce the patient's familiar pain with flexion. There is a shoulder impingement algorithm from Cools et al. That helps you to evaluate the outcome of the near test in two different ways. If the patient complains of anterior shoulder pain during the test, it's more of an indication of subacromial impingement. If the patient complains of posterior pain during the test, this is more of an indication of an internal derangement. The painful arc test is considered a hallmark sign for patients with subacromial pain syndrome. Hedges et al. In 2012 reviewed the literature on which physical examination test provides clinicians with the most value when examining the shoulder. Their review revealed a sensitivity of 53% and specificity of 76%. Ask the patient to slowly abduct the arm with the thumbs pointing upwards. If there is pain going upward from 60 to 120 degrees, this is an indication of a subacromial impingement. If you find pain only from 170 to 180 degrees of abduction, this could be an indication of an acromioclavicular problem. The Yoakum test is an active maneuver designed to test the structures of the subacromial space. The Yoakum test underwent tests for diagnostic accuracy assessment. In a 2008 study by Silva et al., they report a sensitivity of 79% and a specificity of 40% when compared to MRI classification of supraspinatus tendinopathy, and sensitivity of 80% and specificity of 36% when compared to MRI classification of subacromial subdeltoid bursitis. The size of the study was very small. To perform the test, the patient is sitting or standing. Ask the patient to place the hand of the affected arm on the contralateral shoulder. Then the patient is asked to raise the elbow without moving the shoulder. The test is positive if the familiar pain is reproduced. According to a study conducted by Miller et al. In 2008, the drop arm sign has a sensitivity rate of 73% and a specificity of 77% in the diagnosis of full thickness tears of the supra and infraspinatus muscles. To perform the drop arm sign, have the patient in standing or sitting. You bring the arm of the patient passively into abduction and external rotation to about 90 degrees. Have the patient hold this position. Release your hand, and if the patient drops the arm, it is positive for a full thickness tear of the supraspinatus and infraspinatus. If they are unable to hold the arm or slowly lower the arm to the side. The Jagerson's test is used to test pathology of the transverse ligament that holds the biceps tendon in the bicipital groove. According to research done by Microli in 2015, this test has a sensitivity of 32% and specificity of 88% for biceps pathology. In another study in 2008, the Jagerson's test was shown to have a sensitivity of 12% and specificity of 87% for SLAP lesions. To perform the test, have your patient's elbow flexed to 90 degrees with the forearm in full pronation and the arm is stabilized against the body. Ask the patient to perform supination while you resist the movement. Make sure that you're palpating in the bicipital groove at the same time. If you feel the biceps tendon popping out of the groove, this is an indicator of a tear of the transverse humeral ligament. Tenderness or pain without a pop is an indicator for biceps tenosis or a SLAP lesion. Thank you for taking the time to view the Border Therapy Special Test training videos. If you have any other topics that you would like us to discuss, please do not hesitate to reach out to one of our marketing specialists.